Vuyo, you can start sharing your screen. Okay. So good afternoon, everyone. Today, Dr. Vuyo Nogela is going to talk about compartment syndrome, so limb and abdominal compartment syndrome. Okay, Vuyo, you can go. Vuyo, can you unmute yourself? Okay, okay, good. Okay, you can start.
I'll start the talk with abdominal compartment syndrome, and then I'll move on to the limbs. So first of all, compartment syndrome is a circulatory disturbance that is caused by interstitial pressure in a closed osteofacial compartment, rising to the point where the perfusion is reduced. So this results in loss of function and also necrosis of the muscles and the nerves that are in the compartment unless the compartment pressure is relieved. So it may affect every anatomical area, including the head, chest, abdomen, and extremities. There is described polycompartmental syndrome where you find compartment syndrome in more than one defined area. Like if you have compartment syndrome in the chest or as well as the extremities, that would be defined as a polycompartment syndrome. Right. I'm having some difficulty. I just want to, okay. All right, so abdominal compartment syndrome, it was first described by Folkman when he discovered the sequelae of an compartment syndrome that is not managed, which was the Folkman's contracture. And then later, Hammond and others, as well as Richard and others, demonstrated how the raised abdominal pressure adversely affects renal function and how abdominal decompression improves it. And then in the late 1980s, the ICUs started measuring it via a urinary catheter. And the first time that the term was used was in 1989. So intra-abdominal hypertension refers to an increase in intra-abdominal pressure before overt signs appear. So you may have an increase in the abdominal pressure, but patient doesn't exhibit any signs as yet. And then the term abdominal compartment syndrome occurs when the elevated intra-abdominal pressure causes dysfunction in one or more organ systems. So the intra-abdominal hypertension is more of a prodrome, or like a precursor. It happens before you actually get the syndrome. So it's important to be able to recognize it before it progresses to an abdominal compartment syndrome. And then there is a World Society of Abdominal Compartment Syndrome that has guidelines every 2 years on how to manage patients with abdominal compartment syndrome, they give recommendations. So the last meeting was in 2017, and I just thought I should add some definitions that were described in the guidelines. They keep changing, but the most important things, usually they stay the same. Intra-abdominal pressure is described as pressure concealed within the abdominal cavity. And then there's abdominal perfusion pressure, which was previously used as an endpoint of resuscitation. It's no longer being used. Some people still use it in their management as far as endpoints of resuscitation are concerned, as well as also defining abdominal compartment syndrome. It's basically mean arterial pressure minus the intra-abdominal pressure that gives you the abdominal perfusion pressure. The intra-abdominal pressure is measured in millimeters of mercury, and it's measured at end expiration. Patient has to be in a complete supine position with no abdominal muscle contractions, and the transducer is zeroed at the mid-axillary line. That's something that has changed over the past couple of years, because previously we were told or were taught that it's zeroed at the pubic symphysis. So the normal intra-abdominal pressure is 5 to 7 in critically ill adults. I couldn't find a definition for children. And then intra-abdominal hypertension is a sustained or repeated pathologic elevation of the intra-abdominal pressure to above or equal 12. And then when it is sustained more than 20 or associated with new organ dysfunction or failure, that's when you classify it as abdominal compartment syndrome. Then there are also defined primary and secondary abdominal compartment syndrome. Primary is anything, a cause of abdominal compartment syndrome that is arises from the abdominal pelvic compartment, but anything that causes an abdominal compartment syndrome that is not from the abdominal pelvic compartment, that would be that doesn't arise primarily from there, that would be classified as a secondary abdominal compartment syndrome. An example is when you have abdominal compartment syndrome after over resuscitation, giving a lot of fluids without considering the fluid balance. And then they also describe recurrent, which is basically a patient that previously managed either medically or surgically with abdominal compartment syndrome, and then later is diagnosed with the same problem. Etiology, the different classifications in terms of what how to classify the different causes, but this is the one that I chose. Either you have retroperitoneal, intraperitoneal, as well as abdominal wall causes. And the most important with the retroperitoneal is pancreatitis, as well as the hemorrhage, and then intraperitoneal is written. And then abdominal wall, which is also important for us because that's where you have repair of gastroschisis, non-phalangeal, the congenital abdominal wall defects that we deal with, as well as patients with burns, where they might need some, where they might have some eschar which forms causing an abdominal compartment syndrome. And anything, any patient that had a laparotomy that is closed under tension. When it comes to the pathophysiology, the manifestations of abdominal compartment syndrome are similar to those of shock. The sympathetic nervous system mediated vasoconstriction shunts blood to the heart and the brain. And then the hypoxia is associated with release of cytokines, oxygen-free radicals, and decreased ATP production. And all this contribute to the development of intra-abdominal hypertension and later abdominal compartment syndrome. Yeah, the cytokines, they cause a direct damage to the cell membranes. They might lead to increased permeability, which contributes to edema. The oxygen-free radicals also cause direct injury to the cell membrane. As far as what happens to the body's organs, I think this is a good image which can show the vicious cycle that is described when it comes to abdominal compartment syndrome. So it starts first with a patient that needs fluid resuscitation for critical illness, either a patient who is hypotensive, which is one of the initiating problems that can lead to the abdominal compartment syndrome. So hypotension of any cause that is corrected by fluid resuscitation. So if the patient is a trauma patient who lost a lot of blood, or hypotension of any cause that needs fluid resuscitation, if you don't pay attention to the fluid balance, or you have a positive fluid balance that is not paid attention to, that can lead to total body fluid third spacing or edema. This results in an increase in the intra-abdominal pressure, which may compress the vena cava. This reduces the preload, which reduces the cardiac output. Then there's reduced blood flow to the organs, which leads to a multi-system organ dysfunction or failure. And then once you have all those organ dysfunctions, the resulting thing might be that the patient also becomes hypotensive. Then you continue the cycle again. And then the intra-abdominal hypertension, it can affect all the organs in differing ways. With the brain, it causes mostly an increase in the intracranial pressure. And then in the lungs, it can lead to ventilation perfusion mismatch, which basically which causes hypoxia. So patient basically needs more ventilation, which is why most patients that we see with abdominal compartment syndrome are critically ill patients. As I mentioned, with the heart, you get a decreased cardiac output, and also what is important with the kidneys, because of the decreased renal perfusion, since the blood is being shunted, there's a direct activation of the renin, angiotensin, aldosterone system, and that will lead to oliguria and also acute kidney injury. So with prevention, you need to have an early effective control of the hypotension and hypoxia to prevent bowel edema. Intraoperatively, it's important to keep bowel warm and also not to close the abdomen under tension. And then with the high-risk patients, the recommendation is that you need to monitor the bladder pressure, the intravesical pressure, 4 to 6 hourly. So high risk patients are described in the WS-ACS. Basically, if a patient has 2 to 3 of these risk factors that are here, then you need to have a high index of suspicion that the patient might develop an intra-abdominal hypertension leading to abdominal compartment syndrome. So it's best to monitor the intravesical pressure. How you monitor the abdominal compartment pressure or the intra-abdominal pressure. The gold standard is the urinary bladder pressure or intravesical pressure. It has a high degree of correlation with the intra-abdominal pressure. It's easy to use, it's minimally invasive, and it's safe. It's the conditions that it's unreliable in is a patient who has a small neurogenic bladder, or if there's been bladder trauma or pelvic hematoma, or basically anything that will compress the bladder or injury to the bladder. Other modalities to measure that have been described include a gastric pressure, IVC pressure with the use of a femoral catheter, a direct intraperitoneal puncture, and also, as well as transrectal pressure. But as I said, this one is the gold standard. So measurement, this is the image that I put here is one of the basically ones you can buy. The image on the left to measure the intravesical pressure. It has a catheter that is attached to basically a non-compressible tubing, which is attached to a transducer, which measures the pressure, as well as the syringe to instill saline. So I'll also explain this later, but as I mentioned, we are now using the mid-axillary line to zero the transducer, and the saline that is recommended, they say it's now 25 mils, but they don't mention why these have changed exactly. Diagnosis is by clinical examination and also intra-abdominal pressure measurement. In some patients, you might find that they might have a tense, distended abdomen, but the absence of this doesn't mean that a patient doesn't have abdominal compartment syndrome. And then other signs and symptoms, basically, since most of these patients are critically ill, you might find that they're in respiratory failure, they have high peak inspiratory pressures, decreased pulmonary compliance and cardiac output, tachycardia, hypotension, and oliguria, and later in uric. This is the grading, the current grading.
Vuyo, can you speak a little loudly, please? Some participants cannot hear. Just speak a little slowly and little loudly, please.
Okay, Bob. So this is the current grading as recommended by the WS-ACS. It changes, it has changed from the previous readings, the previous text that I have read, but currently grade 1 is 12 to 15 millimeters of mercury, grade 2, 16 to 20, grade 3, 21 to 25, and grade 4 when the pressures are more than 25. And you get worsening organ dysfunction, as well as which leads to multi-organ failure as the pressures increase. So this is just a table that shows the recommendations basically for managing these patients. So with the ones which grade 1 and 2, they usually don't need surgery, but they need more of close monitoring and also volume expansion if it's feasible. And then as the pressures go up, these patients might need decompression. And then with the grade 4, all of them, as far as the recommendations, all of them require decompression either by laparotomy or with the burns patients might need an escharotomy. And then there has been recommendations for doing a percutaneous drainage if there is a tense ascites. So as I mentioned, with the management, firstly, it's supportive care. Patients might need sedation and analgesia, nasogastric tube to decompress the bowel, and also you need to correct any positive fluid balance. So patient needs a strict input and output so that you will be able to see if there's any over resuscitation that is happening. And also optimize ventilation. The definitive management is by abdominal decompression, as I mentioned, which is a laparotomy. Am I being loud enough now? Okay.
Yes, I think you are better. Yes. Yeah.
Okay. So exceptions for this, for doing a laparotomy, as I mentioned, patients with burns, they will need an escharotomy, and patients with tense ascites, they will need a percutaneous drainage. They even mentioned that you can even do a percutaneous drainage of ascites, even if you're planning to take the patient for a laparotomy, as it might relieve the compartment and help with the overall clinical condition of the patient prior to theater. And then in theater, if the fascia, when you're closing, it remains under tension, you may leave the abdomen open to prevent an abdominal compartment syndrome. There are different things that you can use to keep the abdomen open, but the one that has been recommended now is the vacuum assisted closure of the abdomen. There are others that we are familiar with, for example, what we use in the kids, the silo. The adults, they previously had the Bogota bag that they were using, and also there's been towel clip closure that was previously described, but I don't think it's been done anymore. Yes, and then you plan for definitive closure within 2 weeks. If not feasible, then the different also options such as skin flaps or doing a skin graft or a composite mesh. This is just an image showing an open abdomen, what I mean by an open abdomen, and this is an example of the vacuum assisted closure. This one is also quite good because you'll be able to see the bowel, and if there's any damage, if there's any like change in the bowel, you'll be able to see. Whereas with the other types of open abdomens, like previously, you couldn't see what was happening, and most of them, they described the towel clips, as well as the one where they used to just put a dressing over it. it could lead to more serosal tears as well as fistulas, and you don't really know what's happening inside. And then I'll just go to the compartment syndrome of the limbs. The causes they are classified under increased. So the different causes, it depends on what it does basically to the compartment. It's either there'll be an increased size of the compartmental contents or a reduced size of the compartment. Both of these lead to a compartment syndrome. So the examples under these, anything that causes an edema, trauma, crash injury, snake bite is also under this. Hemorrhage, also post-ischemic swelling, and extravasation of IV infusions. And then a reduced size of the compartment if the fascia is tightly sutured, if you have circumferential burns or constrictive dressings. Predisposing factors, anything that reduces perfusion pressure, anything that leads to a tendency to edema, traction, and since we're talking about the limb compartment syndrome, it's usually with the kids that have fractures. The traction might also be a predisposing factor, and also an intact facial envelope. This just to mention on the tissue survival, muscle and the nerve. If there's any when it comes to the muscle and the nerve, if there's any problem with the between these two, this is just to show that, as I mentioned, if there's a prolonged time where there is a compartment syndrome of the limb, if it goes above 8 hours, that's where you find irreversible changes. So within 2 to 4 hours between the two, you can have reversible changes. But any time after 8 hours, that's where you find necrosis and nerve damage, which is irreversible. And then this, just the different limbs and also the different compartments that you find. I'm not gonna stay too much on these, but just to mention with the forearm that you have 3 compartments, and also the nerves that you find in each compartment, and that when you're doing the fasciotomy, which is the definitive surgery for this, you have to keep in mind that you need to basically decompress all the compartments. Same as for the leg, where you have 4 compartments. Clinical features for the compartment syndrome: you have pain that is out of proportion, paresthesia, you have pain on passive stretching, paralysis is a late finding. You also have poikilothermia, pulselessness is also a late finding, and then pallor. And on palpation of the compartment, you find that it's tense and tender. Differential diagnosis. The difficulty with compartment syndrome is that some conditions might present with the clinical features that are similar to compartment syndrome. So these are some of the differentials. Investigations, same as for abdominal compartment syndrome, you need to measure the intracompartmental pressure, but there has been widely differing pressures that different authors regard as being significant. But what is important is that when you're measuring the pressure, it's not for a single reading, but for to keep in mind that to record. So if there's a repeated or sustained increase in pressure, then that is significant. But I'll mention the different pressures that have been recommended by different authors. And also, and then with investigations, these investigations basically it depends on the cause of the compartment syndrome. So some investigations help with differential diagnosis, and some just help in managing the patients that comes after trauma with the compartment syndrome, and things like snake bite that you have to do a coagulation profile, etc. As well as even with the radiological investigations. If you have, if you are unsure, they help with differentiating the diagnosis. Intracompartmental pressure, the method that I will describe is the Whiteside method, which is it doesn't require specialized equipment. It uses things that we basically can find. It doesn't have specialized equipment. The other described modalities to measure intracompartmental pressure, the wick or slit catheter, and also low volume infusion systems. These I'll just talk about it when I'm explaining later. And then with the transducers, initially the Whiteside method used the manometer, but now we're using transducers, which are more accurate and a convenient pressure measurement. But when it comes to anything that measures the intracompartmental pressures, the basics principles are the same. There was also there was a suggestion of pulse oximetry, and that it could basically be a reliable indicator of increased intracompartmental pressure, but it was refuted by Mars and Hadley. So this is just an image of the Whiteside method to measure intracompartmental pressure. On the right is the needle they described using an 18 gauge needle into the compartment that you want to assess, that is attached to a 3-way stopcock and attached to a 20 ml syringe that has saline, and then the IV extension tube is attached to a manometer. Now it's being attached to a transducer. So what happens is that once you've opened the system, you can depress the syringe and allow air to go into the compartment. As soon as the pressure in the compartment and the system is equal, saline will start to flow, and you will get a pressure reading on the manometer, which is equal to the intracompartmental pressure.
We are going to end this meeting, and then we'll start the next meeting because there's just about one minute left. Okay.
Okay.
Okay, so I'm just going to end this meeting and we'll start the next one. Okay, Vuyo, you can start again as soon as you are ready.
Okay. Um. So yeah. So I didn't know how to. Okay. Firstly, there's been a few studies that have been done by Mars and Headley, Prof. Headley, which have contributed to the management of compartment syndrome in children as well as adults. I'll mention their recommendations as far as when to intervene. What I'll just say about the ones that I haven't incorporated in the talk is the one about reducing the trauma of direct intracompartmental pressure measurement for children, which he basically was checking, since I mentioned that with the wide sides method for intracompartmental pressure, they're using an 18 gauge needle. And he saw that that was causing like trauma to the children as well as anxiety to the parents. And if there's any difference in using the small sized needles, like the 25 gauge for children, and there was basically no difference. And the small diameter needles are reliable, are as reliable as the 18 gauge needles. Yeah. And I did mention about the pulse oximetry, that it's not reliable in intracompartmental pressure. And when it comes to treatment, emergency measures are to correct any tendency to hypotension, reduce a displaced fracture. If there's a constricting dressing or plaster, you need to remove it. And then the definitive treatment is a fasciotomy. You can consider prophylactic fasciotomy if there's been arterial occlusion more than 4 hours, or if you have a patient that has a fracture that needs internal fixation and you expecting some severe swelling. And there's also other described modalities like IV mannitol and hyperbaric oxygen therapy that are basically not in use, but I just thought I should mention. Mars and Headley proposed surgery in adults with compartmental pressure within 20 millimeters of mercury of the diastolic, and in children when it is within 30 millimeters of mercury of the mean arterial pressure. And then, as I said, there's differing recommendations by different authors. And Mubarak and others, they recommend fasciotomy if patient is normotensive, that you have positive clinical findings, the compartmental pressure is more than 30 millimeters of mercury, or if you, as well as if the duration of the increased pressure is unknown or more than 8 hours. Also, if a patient is uncooperative or unconscious, but the compartmental pressure is more than 30, and also with hypotensive patients with a compartmental pressure more than 20. Others use delta pressure, which is mean arterial pressure minus the intracompartmental pressure, and they institute therapy if the difference is less than 40 millimeters of mercury. A contraindication to fasciotomy is a patient who has a missed compartment syndrome. There's differing times. Others say 24 to 48 hours. Others can be 36 up to 72 hours. There's no, they found that there's no benefit in doing the fasciotomy because there's already irreversible damage to the muscles and the nerves. So the fasciotomy will offer no benefit to the patient. So when it comes to fasciotomy, early diagnosis is important. You need to make long extensile incisions to release all the compartments, preserve neurovascular structures, debride any necrotic tissue if there is, and cosmesis is not a consideration with these patients. And then you need to aim for coverage within 7 to 10 days. This is just to mention the different incisions for the limb compartment syndrome. The one that has been described for the leg, there are two basically. You can either do 2 incisions, medial and lateral. I found these pictures better because they show the surface anatomy well. So you do an posterior medial incision, and as well as anterior lateral incision. And then there's the single incision that has also been described, where you do it laterally from the fibula up to the ankle. And then the picture on the right shows fasciotomies of the forearm and the hand. So with the hand, the one that is described for the palm, the incision is a lazy S incision. It starts above the antitubital fossa, and basically you go down. This is it doesn't depict it well, the actual lazy S, but the important part is that you also need to decompress the carpal tunnel, and then the dorsal forearm as well to decompress those muscles. And then this also shows for the hands. The hand has 10 compartments that you also need to decompress depending on where the compartment syndrome is. This is also just showing the surface anatomy and the incisions for fasciotomy. This picture shows the lazy S that I was mentioning to decompress the forearm, and the thenar and hypothenar incisions for the hand. And that is for the thigh. Complications, infection usually occurs if there's extensive muscle necrosis. So as I mentioned, you need to aggressively debride, and then also appropriate antibiotics after debridement. Other complications are hyperkalemia and myoglobinuria, which occur after revascularization of the ischemic muscle. This might also cause renal failure in some patients. So it's important that you make sure to monitor these patients post-op. And then Volkmann's ischemic contracture, that is the claw-like deformity of the hand. It's also been a similar condition has been described for the feet, for the foot, when for patients who had a compartment syndrome that was basically untreated almost. That's when the necrotic tissue heals by fibrosis. So these patients have a permanent morbidity that is related to that. Other complications include post-traumatic ossification, chronic pain, and then related to the fasciotomy, altered sensation, dry, scaly skin, swollen limbs, pruritus. discolored wounds. This is an image that at the bottom it shows the Falkman's contracture, and the top is just for an African perspective for children who are managed by, they call them bone setters, who are basically like traditional healers who specialize in managing bones and musculoskeletal problems. So I was just reading for an African perspective on compartment syndrome, and some children in areas like Nigeria and Kenya who are being managed by bone setters develop compartment syndrome and later have this Falkman's contracture because the syndrome is missed in these kids. In conclusion, the earlier compartment syndrome is diagnosed and treated, the better the prognosis. It is important to recognize intra-abdominal hypertension early before progression to abdominal compartment syndrome. Most patients who develop abdominal compartment syndrome are critically ill and unable to communicate, necessitating the need for a high index of suspicion. Repeated or sustained intra-abdominal pressure is more valuable than a single reading, and a delay of more than 12 hours will leave the majority of patients with a permanent disability, particularly with the limb compartment syndrome. Thank you.
Okay, Vuyo. That's very good, Vuyo. And your references are good. Your understanding is good. Your presentation and conclusion were also fine. Before I invite comments, I just want us to remind ourselves is that perforated appendix with generalized peritonitis per se can also cause abdominal compartment syndrome. And we just need to keep that in mind, that these patients can also develop abdominal compartment syndrome. I just asked Selo to comment first. Selo, if you can unmute yourself, please.
Sure, Prof.
Yes.
Thanks, Vuyo. That was quite concise. I won't add a lot. I'll just say things here and there. When it comes to any kind of compartment syndrome, I think the important thing is suspicion. Without suspicion, you won't investigate it further. And if you don't investigate it further, you're going to miss it and you're going to have more complications. Simple one is someone coming in with a depressed GCS who has a fracture to the arm or something like that, or what we see typically is a child who comes in with a envenomation, so has been bitten by a snake and the arm is quite tense, but the child is not communicating well with you. So it's those situations where you would want to address the compartment syndrome, or when you're querying that compartment syndrome, just address it early before you actually wait for lots and lots of investigations and further delay. As you know, with as I gave a clear example there of envenomation, the trauma ones, they would be more seen by orthopedic surgeons and so forth. But when we, with our settings, what we see all the time is a child who is in nursery who has IV line running and it extravasates into the tissue. And what always happens, which is what I always try to enforce and remind everyone, is that when someone has fluid that's infiltrating into the tissue, try not to elevate the arm above the head. You want to maintain arterial perfusion to that limb. So what's recommended is that you keep the limb at the same level as the heart. Obviously, logic tells you that if you elevate the arm above the head, the edema will settle and so will the compartment syndrome or the increased pressure within this facial plane. But by increasing the limb, you are decreasing the perfusion of blood going there. So you don't want to do that. So that's the thing that we must always just try to remember. So these kids have had IV lines that infiltrated, and we get called in 2 or 3 days down the line. The arm is quite hard. The child might not necessarily be crying all the time, but it's quite hard at the time, and you think it's a compartment syndrome. That's where you would earn the side of exploring. Sometimes they would give us a history of the child has had a drip infiltrated, and you've tried to elevate the limb for the past 2-3 days. And as you said in your presentation, that it's contraindicated to do any kind of fasciotomy after 48 to 72 hours. But remember, ultimately, if you are suspecting it and you're not sure of the actual duration, so even the pediatricians would say, yeah, it's been hanging for 2-3 days, but they're not really 100% sure. It's worthwhile to go in. Obviously, if you're seeing that the limb is not salvageable, meaning that there's already fixed staining in the limb and already has contractures, that already shows you that there's no point in doing a fasciotomy. But if the limb still looks viable, it's worthwhile doing a fasciotomy to assess the compartments and assess the muscle viability, so we can proceed from then onwards. So that's why it's important to know that with the older patients, that when you're looking at the P's, because that's the thing when you're looking at compartment syndrome, we look at all those 5 P's. The important P is pain, which is usually out of proportion, and paresthesia, because with the pain, that's because there's increased tension with the osteo or myofascial plane, so that causes pain, so that causes pain. Plus, there's also associated anaerobic respiration, anaerobic cell metabolism that causes lactic buildup, that causes pain. So that's usually earlier on. And as associated with that is the paresthesia, because the nerve fibers are bathed in these toxins. So that happens very, very early. By the time you have your pulse that's gone or your limb that's pale, usually the limb is gone. It's not salvageable. So if you don't have an index of suspicion early on, you're gonna miss the boat. And that's why I'm saying that if you think it's compartment syndrome, the safest and best thing to do would be to do a fasciotomy. It's easier to deal with a tissue that's already open. You can easily suture it or easily do a skin graft. It's very difficult to grow a new hand or a new foot. So always think in your head, if you think it's a compartment syndrome, do a fasciotomy as soon as feasible. The longer the delay, the more problems you'll get. The pressures are important, I think, as much as there's lots of debate as to what values you should use, or you should use 30, 20, whatever. I think what's important is that you must use your patient. You must look at the patient and see how they are. As you rightfully said, a normotensive patient with pressures above 30, that's problematic, because if you're normotensive, you're still perfusing your limb. But if your pressure within that limb is above 30, that means that your capillary perfusion pressure, which is 25 millimeters of mercury, it's important for anyone who's doing intermediates to know that the capillary perfusion pressure is 25. That's why these studies, they use values of 30, because obviously if it's above the capillary perfusion pressure, that means that there is no flow and there will be ischemia in that limb. So that's why with a normal person you use 30, and with someone who's hypotensive, so already the blood pressure is on the low side and the GCS may be depressed, so they might not be able to verbally articulate that there is pain out of proportion when you're either touching the compartment or trying to do those passive stretches, which some people say they're contraindicated now. So when these hypotensive people come, you always just decrease the pressure requirements for a fasciotomy to 20, as you mentioned. But as I said, even if you get a pressure of 15 or borderline 10 to 15, but you're still not happy, it's always the safest thing to do is to do a fasciotomy. Then you can deal with the consequences later. Yeah, I think what's also important with like abdominal compartment syndrome is, especially with our setting, we don't routinely measure the the abdominal pressure with a urinary, with the way that you articulated by putting in a urinary catheter. We measure or assess the chances of you having intra-abdominal compartment syndrome by looking at your vital signs. So we look at simple things like your urine output. As your urine output started going down, if you're ventilated, how's your tidal volume and how's your airway pressure? Because with splinting of your diaphragm, your tidal volumes drop and your peak airway pressures rise. So these are very, very important parameters in someone, you look in someone, especially gastroschisis or omphalocele, anyone that you're closing an abdomen. Always before you close the abdomen, you look or you ask the anesthetist, what's the airway pressure? And after you close, you assess the airway pressure again, because that will tell you that, okay, there was significant change to airway pressure after you close the abdomen, or the airway pressure remained the same. Then you can kind of say, okay, it's safe to close the fascia, it's safe to close the skin, and I can further monitor the patient in ICU. So it's not just by measure. In my limited experience, I have not measured in a child the pressures in the abdomen. We always use parameters. Those clinical parameters are way more important than trying to measure with a catheter. And when we're dealing with an abdomen, so an open abdomen is much better than a closed abdomen when it comes to abdominal pressure. But obviously we know with an open abdomen comes the risk of fluid loss, comes the risk of sepsis. So we always try to close the abdomen if we can. So if you can't close the sheath, I always recommend that you try to close the skin at least, because the skin is at least more pliable. So it might give you leeway and not cause persistently elevated pressures post-closure. So if you see that you close the sheath, the pressure shot up, open the sheath and try to close the skin and see if the changes are remarkable or not. If the changes are huge, then obviously you can opt for vacuum assisted closure, which it's ultimately it's the same as a Bergota bag, because Bergota bag ultimately you just put any kind of transparent bag above the bowel with attached tubing to suck all the fluid that's coming out, because that's exactly what a vacuum assisted closure does. But vacuum assisted closure, it's more for trying to close the abdomen staged way, so that over time it helps with granulation, and ultimately, unfortunately, you'll end up with a huge ventral hernia, which obviously can always address as time goes on. But and last but not least, regarding someone with ascites or doing any TT type, so you can do the same way that